All right, so we are talking about the appendicular skeleton today and looking at the joint, synovial joint, specifically the knee joint. We're on page 12 in the blank packet that you have. And looking at the appendicular skeleton and comparing it to the axial skeleton, we can see here that the axial skeleton is shown in green, and it kind of serves as the major framework of which the appendicular skeleton comes off of. So the arms and the legs, the hips and the shoulders, those bones that make up those major regions or joints make up the appendicular skeleton. Think of the word appendage. So pectoral girdle refers to the bones that make up the shoulder joint. So the clavicle with the scapula and the humerus make up the pectoral girdle. And the pelvic girdle is the bones that make up the hip. So specifically the three fused bones of the hip, or of the coxal bones, which are here, os coxa, and then the femur, head of the femur coming together to form the hip. So we'll talk about each of the bones of the appendicular skeleton. So the first one on page 12 is the clavicle. We call this our collarbone. It's kind of a flattened S-shaped bone, and it articulates with the manubrium of the sternum and the top of the scapula. So it has two articulation points. And when you look in high school sports, where we see a lot of broken collarbones is in hockey, when you have kind of tall, thin, young men that are getting checked sideways into the board. The pressure exerted in that horizontal direction of this bone usually breaks that clavicle. But because there's so much movement in the shoulder, they don't really set that bone unless it's completely cracked in half and not lined up correctly. But oftentimes it's just cracked, and they just kind of let it go. They just, immobilize the arm a little bit for a couple weeks, and they just let that bone heal on its own. And a person might have a bump there because it didn't heal perfectly, but they don't usually do much more than that. They just leave those fractures alone and just, immobilize the arm a little bit, and that's about all. So that's the clavicle or the collarbone. The scapula, what do we call that out on the street in the everyday conversation? Yeah, the shoulder blade. So if we look at the front side of the shoulder blade, you can see this here. And then the back side, there's this ridge here that comes back, and the muscles of the back attach there and the shoulder. So there's a couple of parts of the scapula that you need to know. One is the glenoid cavity, and that's this smooth area right here where the humerus rotates. So on this diagram here, it's this curved surface right here where the head of the humerus sits. So this is the glenoid cavity, just that specific spot right there where that fossa is another name for it, glenoid fossa, just that spot where that humerus would rotate. And then the spine is this ridge across the back. So all of this is spine. So let's call this the spine. And then it ends in this large piece that holds the humerus in place. So when I put the humerus on this bone here, I can see that the humerus is prevented from moving upward because of this acromion that holds it in place. So this enlarged end here of the spine is called the acromion. So we have the spine ending in the large acromion. And that's the scapula. So then we move down to the arm, upper arm, which is the humerus. And again, we always have a front and back view. So here is our front view. This is our posterior view. So the humerus has a rounded head. So the head of the humerus is just this rounded portion here. And in looking at any joint that has full rotation and a circular motion, we're going to see this rounded head. So we see this at the hip as well. So this view here is the anterior view, like I said. And notice there's two swellings here at the top on the head. And those swellings are called tubercles. So one is a little higher up. So this swelling here is a little higher, and then this one's just a little bit lower on the humerus. We have the greater and lesser tubercle. So anytime we see these swellings, they start with a T. So there's tubercle. If there's more than one, tubercle. If there's just one, we call it a tuberosity. And if they're really big, we call it a trochanter. So you're going to see those T words. And when you see the T words, think bumps on the surface of bone for ligament or tendon attachment. So we have the greater and lesser tubercle, and in between there is a groove. Inter means between. So that's the intertubercular groove. So that's right here at the top of this bone coming down, the intertubercular groove. So there might be nerves that lie in between here, ligaments, tendons, intertubercular groove on the anterior side of the humerus. So we talked about the greater tubercle, lesser tubercle. And then we have the olecranon fossa. On the back side of the humerus, if we turn it over, there's this little indented region. I could put my finger in it. And that's where the elbow joint is, and the head of the top end of the radius fits in, or I'm sorry, the ulna fits in there to form the elbow joint. So it fits right in that little hole right there, which is the olecranon fossa. So that's on the back side or the posterior side of the humerus. Then we get to the lower arm. There's two bones in the lower arm. So here we can see that here's the top of that ulna fitting into the olecranon fossa, which is this indented space right here, which is that. So there's two bones that articulate or move against the humerus. We have the ulna and the radius. So the top of the radius we can see has this rounded, almost suction cup-like end. So look for the rounded end of the radius. And when I say rounded, I think of a radial tire, radius. Some people say it almost looks like a suction cup because it's indented there. So it can articulate with the humerus. So this is a radius. And the thing you need to know about the radius, there's one single bump here up at the top of the radius right here, that little swelling right there. That is the radial tuberosity. And because there's only one, we call it a tuberosity rather than a tubercle. So that's the radial tuberosity, that big swelling right there. And at the bottom is a little projection pointing downward at the bottom, which forms the bump of your wrist. So the radius lines up with your thumb. So this bump down here, that large bump that extends downward, so here and here, that pointed region is called the styloid process. There's two bones that make up your wrist. You can kind of feel those bumps if you have a thin wrist. The one on the thumb side is the styloid process. The one on the other side is also called the styloid process, but it's part of the other lower arm bone, which is the ulna. So to identify the radius, look for that rounded end, and that'll tell you right away you're looking at the radius. And then, again, radial tuberosity and styloid process. And a nice way to find, or to remember the name of the other arm bone is this U-shaped end, and it starts with a U, and that's the ulna. So you can see it has this U-shaped end here. And remember the tip of that part, the tip of that U is what hooks into the olecranon fossa. So this tip, that pointed tip, is called the olecranon process because it hooks into the olecranon fossa of the humerus, that little groove in the at the inferior end of the humerus. So this is the olecranon process. And then on the opposite end, down where the hand would be, is this little pointy projection down here, which is called, just like we saw it on the radius, the styloid process. So that little pointed end there. And you can kind of remember this because when you write with the stylus, aren't you moving your wrist? Thank you very much. So there's the other styloid process on the ulna. So look for that U-shaped end, and it starts with U. Then we have the hand, and we are not going to separate the hand and finger bones from one another, so you'll be okay in terms of knowing how to name these. They'll all be together. So if we start at the wrist, we have these short bones. Remember when we classify bones we talked about in the last lab? These are the short bones of the wrist, and they're called the carpals. So these are the carpals down here, these short little bones that form the wrist, and they allow you to rotate your hand because they glide past one another. And then we have these bones here that have the numbers on them, 1 through 5. These are called the metacarpals. So carpals are the short little wrist bones, and then the bones that make up the bulk of your hand, the palm of your hand, are called metacarpals. So we have just one of those metacarpals from each finger, and then the phalanges are the finger bones, and there's 3 finger bones that make up the phalanges, so 1, 2, 3, except for the thumb. The thumb only has 2 phalanges, 2 bones that make up the phalanges. Now each of these bones has its own name, but if you were going into surgery, orthopedic surgery, and you were a hand surgeon, then you would know all these bones. But for our purposes, we just want you to know the group name. So we've got the carpals, the metacarpals. Meta means middle, so they're in the middle between the carpals and the phalanges. So metacarpals and phalanges on the end. Carpals, metacarpals, phalanges. And if we look at the foot, we'll see the foot is named in a similar way. So I'm just going to jump down there. If you would go to the end of your lab packet, because I think it's easier to talk about these in comparison. So this is on page 13, the end of objective 2. So the bones that make up the ankle, the shortened bones that make up the ankle, are called tarsals. These would be called metatarsals. So what makes up the arch of your foot are the metatarsals. And then again, the last 3 bones, except for the big toe, only has 2, just like the thumb only has 2, but the last 3 bones of each toe are also called phalanges. So phalanges, metatarsals, and the chunky bones of the ankle and heel are the tarsals. So how do we distinguish carpals from tarsals, metatarsals, metacarpals? A good way to keep that straight in your mind is that we clap with our carpals and we tap with our tarsals. So that'll help you with the foot versus the hand and remembering those terms. And then there's 2 bones you have to zero in on in the ankle, and the one is the heel, and the other one that rotates with the tibia. And those bones are the talus, which is this bone where the radius sits on. It allows you to tap your foot. That rotating grooved surface here is where the tibia sits and allows you to rotate your, allows you to tap your foot because of that grooved surface. That's the talus. And then we have the calcaneus, which is your heel. Now there's a connective tissue sheet called the plantar fascia that attaches to the back of the heel and stretches across the bottom of the foot and attaches to the back of the toes, at the base of the toes. It's called the plantar fascia. So if you have good arch, the plantar fascia, and it's well supported by good shoes, if you're on your feet a lot, the plantar fascia is intact and happy and healthy. But if you gain weight, I developed this during one of my pregnancies. It was terrible. I had it for 3 years. It's called plantar fasciitis. And I have a little bit of flat feet on top of rapid weight gain. And what happened is it starts to tear the plantar fascia away from the attachment points. And you get a lot of heel pain and foot pain. And the best way to know if you have plantar fasciitis is when you step on your feet in the morning, if it feels tender, and then gets progressively worse throughout the day as that inflammation builds up. And then when you go to bed at night, it tries to heal. But when you're in bed, your foot is kind of curved a little bit inward, so then it heals inappropriately. So when you stand on it and stretch it out again, you tear the plantar fascia, and you end up in this vicious cycle of pain and inflammation. And the best way to treat plantar fasciitis is to have a hard support, arch support in your shoe. And wear quality shoes. There's a lot of cheap shoes out there, especially for women, right? And those are killers for plantar fasciitis. You have to really take care of those arches if you're suffering from this. And when you spend a lot of time in your feet, like in healthcare, you know, you're more at risk for sure. So a hard arch support. Buying the squishy Dr. Scholl's, your weight is going to squish that arch support down and you're not going to get that good support. So you need a hard insole. So you can usually get that from like a chiropractor's office or a podiatrist's office, or you can buy kind of a one-size-fits-all at Target. They're called walk fits, and they're hard white plastic with different versions of arch support. And I bought a pair of those for my nursing shoes, and they work great. So really, really important to have good shoes if you suffer from plantar fasciitis. Okay, so moving on, and we're going to look at the bones that make up the hip. So we call all these fused bones the pelvic girdle. And in looking at the pelvic girdle, it's made up of two bones that are fused in the middle. This is the pubic symphysis, and this is made up of fibrocartilage. Remember, fibrocartilage is the toughest of the cartilages. It has those thick, kind of wavy collagen fibers, but it is cartilage. So it looks like the fisheye soup, but with lots of wavy lines in it. So that's the pubic symphysis, and each side of this is called an os coxa. So this is an os coxa, all of this here on this side, and this is the os coxa. And from last time we talked about the end of the spine. What is this large bone called? Do you remember? Yeah, the sacrum, and then the tailbone is called the coccyx. So that's what forms the hip. We have the sacrum, the os coxal bones, and then the pubic symphysis holding things together in the front. Well, this joint right here where the sacrum and the os coxa come together, this is called the sacro-iliac joint. So this line on either side is the sacro-iliac joint. And women or SI joint. In women in pregnancy, with the widening of the hips and the changing of the center of gravity as the belly begins to grow, the uterus grows with that developing fetus, they end up with an imbalance in the SI joint. It causes a lot of really low back pain. And the good news is if they see a pregnancy certified chiropractor, they can usually position that back into place and the person will feel great again. I had it happen to me. One of the people I worked with did not see a chiropractor for it. She was miserable her whole pregnancy. I went and saw a chiropractor, popped it right back into place, and it was not an issue again. Maybe you need to be seen more than once, but for me, it worked with one little adjustment. So if you know anybody who's suffering with that, tell them to see a chiropractor. They can pop that right back in place again. Okay, so looking at male versus female, a couple of differences. We have both types in lab. Looking at the female, we can see this arch right here at the bottom of the pelvic girdle. We see that's an obtuse angle, so it's greater than 90 degrees if I would lay this on a flat plane, where this is an acute angle, less than 90 degrees. So it's much wider here. And if I look at the opening, because a baby's got to pass through this space right here, it's much wider here than it is here. Because can you see how narrow the hips are here at the top compared to these are more splayed out to the side? But some women have narrow hips. That's why the designers of jeans came out with the boyfriend fit, right? Because men tend to have more narrow hips, and women that have narrow hips need to wear jeans that will accommodate that body proportion as well. So you will need to distinguish between a male and female pelvis and just look for those characters. The pubic arch is really the biggest way to tell. And if we look at the coccyx as well, we'll see that the coccyx kind of curves inward on the male. So if a baby's trying to pass through there, it's kind of difficult. That coccyx is in the way. Coccyx. This one, it's broken off, but it's a little flatter in the female, so the baby can come through. But sometimes if baby is coming out sunny side up, so if a mother's lying on her back in the kind of traditional medicinal way of giving birth, which isn't always the best way, if the woman's laying on her back and baby comes out facing, looking at the ceiling, that is the wrong position, and that occipital bone is pressing really hard against the coccyx, and that causes a painful back labor for women, and it's more difficult for baby to come out because of that position of that head. It's better for baby to be face down. So female versus male pelvis.
Skeletons are male.
It looks like it, yeah. Good observation. Yeah, I would say so. Okay, moving on then, looking at the parts of the pelvic girdle then. This is on the top of page 13. There's 3 bones, and they're color-coded here, but what you see in lab is not going to be color-coded. So the way to distinguish these 3 bones is this large flanged portion at the top of the os coxa is the ilium. And when you put your hands on your hips, you're putting your hands on the top of your ilium. So we call that part where you put your hands, when you put your hands on your hips, we call this the iliac crest. So the top portion here is the iliac crest. And then if I come down the ilium here and I come inward, I see there's this notch here, and this is the greater sciatic notch. So that curve right there, that curve inward is the greater sciatic notch. And that is where the sciatic nerve comes through. So that just leaves a spot for that sciatic nerve that comes down the back of the thigh. So people that have sciatic nerve issues, it's another issue in pregnancy because of the movement again of the pelvis. It kind of disrupts that nerve and causes a little inflammation. So they'll find that they have kind of a twingy, uncomfortable sensation in the back of their upper thigh, back of their leg. And as a result of that, sitting is uncomfortable. Standing feels better. That sitting kind of stretches that area. So that's the iliac crest, greater sciatic notch. Then once we get past the greater sciatic notch, we're down to the other bone on the bottom, which is the ischium. So if you find the greater sciatic notch, the bone directly below it is the ischium. So there's ilium at the top, ischium at the bottom, and the greater sciatic notch is kind of the dividing area between those 2 bones. So ilium, ischium, they rhyme. And I remember when I took anatomy back when I was a struggling student and didn't have good study habits, I had no idea how to distinguish between these 2. But the way I teach, hopefully to help you distinguish between these 2, is you sit on your ischium. Ischium has the S in it, and ilium is large. It's the largest part of this whole bone. So ilium is large, ischium has the S, we sit on it. So your butt bone, right, when you say, oh, my butt hurts, I'm sitting on these bleachers so long, that's the ischium that you're sitting on that makes you sore. Or if a thin child is sitting on your lap and wiggling around, you can feel that digging into the muscles of your upper leg. That's the ischium. And what you need to know is that swelling on the end of the ischium, this kind of fatter, bonier bottom portion of the ischium, that's called the ischial tuberosity. Again, there's one. And it's kind of a swelling. It's the ischial tuberosity. And then the other part of this bone is this portion. This is where the pubic symphysis cartilage would be. The fibrocartilage would attach here. And this is the pubis. So the pubis is this kind of thinner portion here. On the other side, it's opposite of the ischium, isn't it? So you find the ischium, which is straight down from the greater sciatic notch, and then the pubis sticks out on the other side, and that's where it attaches to find the pubic symphysis. And then on the outer edge of that is the acetabulum. So here's my greater sciatic notch, here's my ischial tuberosity, then I have the acetabulum, which is where the head of the femur goes, and it causes rotation of that hip joint. So the acetabulum is this big cup-like structure. So one other structure I didn't point out yet is this here. This is the ischial spine. Ischial spine, this little projection coming out at the top of the ischium. So ischial spine. So here would be the ischial spine on this colored model. So we have the ischial tuberosity, the big fat part that you sit on, and then the ischial spine here at the top, and then the greater sciatic notch. Questions so far? All right, then we'll look at the femur. And the femur is, we know, the longest, strongest bone in the body. And we have the enlarged head, just like we saw in the humerus. It's got this rounded head to allow rotation of the hip joint. But unlike the humerus, the head of the femur also has a neck. So this extension that extends away from the bone and forms that head is the neck. And this is what breaks when a woman or a man has osteoporosis and when they break their hip. Sometimes they'll just be standing there, and because of that spongy bone, the trabeculae being eaten away, being resorbed by osteoclasts because of not enough calcium in the diet and not enough weight-bearing activity, this really gets really thin and weak, and then it breaks. So they have to replace the whole top of the femur, the head, the neck, and this whole top to do a hip replacement. So the neck divides the two bony projections of the femur, which is called the greater and lesser trochanter. So they have the greater on top and the lesser on the bottom. Greater and lesser trochanter. You can see them on both views here. Greater and lesser trochanter. Greater is always higher up on the bone, closer to the top, if we put it in anatomical position. And then the lower, or lesser, is lower on the bone. So we have the greater and lesser trochanter, which are divided by the neck. And then at the bottom, there's two smooth, kind of rounded edges here. It's hard to see on the front view. It's better seen on the back view. And these are the medial and lateral condyles. So these rounded, kind of smooth ends here. Medial and lateral condyles. Now, how do you know which one is medial and which one is lateral? Lateral means toward the edges, right? Medial means toward the middle of the body when it's in anatomical position. What structure on this bone is on the top could you use as a reference for the medial side? The head. Yeah, the head is on the medial side. So therefore, this would be the medial condyle. So find the head, go directly down from there, medial condyle. And the other side would be the lateral condyle. So just make sure you put that head so it's facing inward. And also, you have to make sure it's not backwards either. So this grooved kind of internal area here, this is the back of the knee. The front of the femur is a little more smooth. It doesn't have that big groove in between the two. So medial, lateral condyle. And then we get down to the lower leg, which is well, let's first of all talk about the kneecap. This is the kneecap. So that's the back side of the kneecap. Has some grooved surfaces there for sliding nicely over the front of this is the knee joint. This is the patella. So this is the back of the patella, front of the patella. Kind of a heart-shaped small bone. Some people, though, that back grooved area isn't very smooth or it doesn't ride nicely over the front of the knee, and they end up with what's called patellofemoral pain. It's just an irritation under the kneecap. So some people in sports where there's a lot of bending of the knee, runners, bikers, basketball players, anywhere there's a lot of running, they get that irritation underneath the kneecap called patellofemoral pain, and that's because it doesn't ride nicely, just because of the shape of the back of that knee. Then we come up with the tibia. The tibia is the larger bone of the lower leg, and that's in contrast to the fibula. That has the L in it. People always get confused and say, is this a tibia or fibula, or is it tibula, fibia? The fibula is little, It's in the lower leg and it's lateral. It has all those L words associated with it and it has the L in its name, fibula. So first we're going to talk about the tibia. The tibia is a large bone. It's kind of triangular at the top. So it's flat at the top and then comes down at an angle. That's the tibia. And at the top of it, it has the medial and lateral condyles. So how do we know medial from lateral in the tibia? Well, the tibia is on the medial side of the lower leg. So we already said that the fibula was lower leg lateral. So the two bumps of your ankle are formed here by these two swellings. So if you find the swelling on the tibia, that's on the medial side of the tibia. So this is called the medial malleolus. That's the inner ankle bone, that bump on the inside of your ankle. That's the tibia. That's the bottom of the tibia, the medial malleolus. So therefore, if I go directly up from that, this groove here would be the medial condyle. So find the malleolus and go directly up on that side and you're at the medial condyle. Medial malleolus at the bottom, medial condyle here at the top. So the other side is the lateral condyle, that groove there. The groove, it's hard to see in this particular picture, but it's just that groove. And here's this groove. So then we have a little bump on the tibia near the top, and this is called the tibial, because there's only one bump. This again is called a tuberosity, tibial tuberosity. And some people that have a lot of rapid growth, so during puberty combined with sports, end up with a condition called Osgood-Schlatter's disease, and it causes the tibial tuberosity to be irritated because there's a ligament that attaches here, and it causes irritation of this bone and it causes extra bone growth. And people end up with big bumps on their knees that are tender during puberty or when they're doing a lot of pounding like basketball or football. It's uncomfortable. And it's more common in males versus females, and it tends to go away with age. But I personally have this, and I struggled with it through my 20s, so it was more of a problem. And even today, if I'm trying to wash the floor on my hands and knees, I can't kneel because those little swellings are what touch the floor, so I have to kind of bend my knee in a funny way to get those not to be in contact with the floor. So it's kind of a hassle. And they do offer a surgery where they shave that down. But I feel like if it's not a huge problem, let it go, and it's tolerable for me. So that's the tibial tuberosity. So then the fibula is a pretty boring bone. It's attached to the tibia. So you have the top of it and the bottom of it. And the only part you need to know is this lateral malleolus, which is the outer ankle bone. It's the outer bump at your ankle. So if I hold this up, like this, there's the lateral malleolus right here and right here. So some people might get nervous and say, well, how do I know? It looks so like such a boring bone. Well, the only thing you need to know is the lateral malleolus. So no matter, if you're confused or not, if you just see this really boring bone, it doesn't look like the radius, right? It's a thin bone, but it doesn't look like the radius. It doesn't have a rounded end. It doesn't have a U-shaped end like the ulna. So your only other choice of a thin, longer bone in the skeleton is the fibula. And the only one structure you need to know on it is the lateral malleolus. So it makes it kind of easy in that sense. You can figure it out by process of elimination. This is a very common bone to get broken, because think about which way does the ankle usually roll. Think of yourself. Which direction do we tend to roll our ankle, outward or inward? Outward for sure, yeah. So when we roll our ankle really hard outward, sometimes we can crack the fibula right about here. Or if you really break your lower leg a good one, sometimes you crack in half the tibia and the fibula. Then you need to have pins because there's nothing to anchor those bones together. Or if it's just the fibula, sometimes they can just set a cast, and if the tibia is intact, it'll just calm down on its own. So you still need a cast because it's broken, but the fibula is more commonly broken than the tibia. Did you have a question?
Well, not really a question. I broke my ankle badly in 4 different places. I had plates and screws and stuff, but my tibia was like sticking out of the skin. Would that have been my medial malleolus?
Well, if you, how far up was it? Like from your ankle, was it above your ankle or?
It was this big bump right here.
Bring your foot up, I can't quite see.
Here, I'll show you.
Okay, she's gonna demonstrate for us. Nice. Okay, so we already talked about the foot. Remember, you tap with your tarsals, you clap with your carpals. So we have the carpals, metacarpals, tarsals, metatarsals, phalanges. So now we'll talk about the joint. So we have the hip, the shoulder, the knee, the elbow, lots of joints in the body, but we're just going to zero in on a typical joint. So where the two bones come together is the articular cartilage, so that's what's shown in blue. We already looked at that. And then there's a membrane that lines this joint space, and we call this the joint cavity, or joint capsule, I should say, sorry. The capsule is the outer lining. So think of like a Tylenol capsule that has a little beads inside of it. So the capsule is the outer lining of the space. So this whole thing is called the joint capsule. It's made up of a couple of different layers we can see, right? So the outer layer shown in white here is called the fibrous capsule. So the outer layer is the fibrous capsule. So again, the capsule is the covering of this space. So we have the fibrous capsule, and then inside of that we have the synovial membrane, which is shown in green here. The synovial membrane. And that membrane secretes a fluid, which is called synovial fluid, and that just reduces friction when these two bones are moving against each other at the joint. Now, if you have an injury to your joint, we know that extra fluid can build up in the synovial cavity, right? Or joint cavity, and then you have swelling. And sometimes doctor has to go in and actually tap the fluid and remove it, from the knee because it's causing so much swelling and discomfort. So that's the joint cavity, is the space inside of here, and it's filled with synovial fluid. So lots of little terms. The capsule, again, refers to the covering that forms the joint cavity. So fibrous capsule and synovial membrane. Then this space is called the joint cavity, articular cartilage, and synovial fluid fills that space. And then looking at the knee, a lot of people have knee issues if you've been in sports or, again, talked about in lecture a little bit. Lifelong obesity is really hard on the knees because when you're walking, running, when I see kids playing sports that are 20 pounds or more overweight, and then oftentimes you see them having knee and ankle problems as a result of that. That's just like, it's like carrying depending on the amount of weight people have, it's like carrying a 4 or 5-year-old on your back and running up and down a soccer field or a basketball court. It's really hard on the joints, and particularly hard on the cartilages of the joint. So we know that the joints are lined with articular cartilage, right? But then there's also these cartilage support structures in between the bones, which are called the menisci. So these cup-like structures between the femur and the tibia are called the menisci, or a meniscus, right? You've heard of someone tearing a meniscus maybe, and it prevents rotation of the joint because they sit in these cup-like structures. The condyles of the femur sit in these menisci. Now here's the fibula. So what do I know about this orientation of the joint? Which side of the joint am I at if I see the fibula right below it? The fibula is medial or lateral, did I say? Lateral, because the fibula has the L in it, so remember that, lateral. So this meniscus here is the lateral meniscus because it's on the same side as the fibula. So therefore, this is the medial meniscus. So that makes for a nice cushion between those joints. But what happens over time is people wear away the cartilage, they damage the menisci, and then the legs start to bow out with age. And you'll see that if you look at older people in the grocery store. Sometimes you'll see they have these legs that bow out to the sides. And or a football player too. Sometimes their knees collapse inward if you look at football players because they've worn away all the cartilages of this joint and it's bone on bone. It's very painful. So that's why they have knee surgery. So then what prevents motion on the outside of the knee are these two collateral ligaments. Collateral, so just think of lateral, they're on the edges of the knee. So we have the medial collateral ligament on the inside, that's the MCL. And when I played soccer in high school years ago, someone came up and kicked me. I don't know how in the heck it happened, but they kicked my lower leg and forced my knee joint to the inside. And I still have a stretch, because we know that that ligaments and tendons don't heal well. I still have a stretched MCL, where my knee joint on the inside is a little looser than it should be. And then on the outside is the lateral collateral ligament. So it's on the same side as the fibula again. So you can use that as your reference point. The lateral collateral ligament.
The lateral to the same side as the fibula?
Correct. Yep. And then we have at the top of the knee, we have, or not, I shouldn't say at the top of the knee, but the top of the tibia, we have a ligament that comes from the top of the tibia and attaches to the back of the femur, and that is the anterior cruciate ligament, or ACL. So that's here. This is the anterior cruciate ligament. And notice that these ligaments cross each other. So the ACL and the PCL, which is behind, the posterior cruciate ligament, comes from the back of the tibia to the front of the femur. That's the posterior cruciate ligament. So they cross each other. Cruce means to cross, so that's where cruciate comes from. You've heard of crucifix, it's a cross, right? So anterior posterior cruciate ligament. And these attach bone to bone. So we have the anterior in the front, posterior in the back. So when someone has a twisting motion, like when they turn suddenly, they can tear the ACL. That's the more common one to be torn because there's more rotation there. And it's very common in female athletes. One mistake, if any of you go into coaching ever, whether you're a guy or a girl in here, if you ever go into coaching female athletes, especially in middle and high school, particularly high school, when the hips widen in women when they're finishing up puberty and done growing, so you're looking at like juniors and senior female athletes, sometimes the coaches do activities like strengthening exercises that really stress and strain these ligaments. And I know when I was in high school basketball in the 80s, 100 years ago, 4 out of 5, I was the only one, 4 out of 5 starters had ligament issues. And some were like, missed the entire senior year of sports because of torn and shredded ACLs. And our point guard simply just turned to pass and fell and ripped everything in her knee. So some of the things we do to female athletes, and I even attended a seminar on this, a sports medicine doctor came in and talked to us and talked about how important it is to strengthen the muscles of the upper leg. So we really have to work on female athletes and males as well, but females even more so, is strengthening the quadriceps and the hamstring, because that tightens and pulls on these ligaments and strengthens them. Is when they're not strong. And we're doing, what are those, every school has a different name. What do you call those exercises where you touch the line and come back, touch the other line, come back? We call them gophers. What did you call them? Suicides. Okay. Yeah, it is suicide for the ligaments in the knee. Very bad. But it's good to do those exercises if they're complemented by good strengthening exercises for the knee. Wall sits are really good for strengthening the knee, because it forces you to bend appropriately, only at a 90-degree angle, and keep the knees over the ankle, right? The knee should never tip over the toes when a person is doing any kind of squats, because that stresses the knee. But we really got to be smart about strengthening the knee joint in female athletes, otherwise you're going to lose those players. And some parents have put a lot of time and money into their female athletes. My daughter's only 7, and she has some friends that are traveling to Madison to play elite soccer, and they're in 2nd grade. I mean, hundreds and hundreds of dollars is being spent just to get into their, high school career, and then they blow a knee and they're done playing sports. So very important to strengthen that knee joint. And these are the muscles that need to be strong and support the knee joint. So looking at those muscles, then we have the patellar that's embedded in, now they say this is embedded in a tendon because muscle to bone. So you're going to see some disagreement out in the field about what we name these structures above and below the patella. In textbooks, we call it the patellar ligament below the kneecap and the patellar tendon above the kneecap, because tendons attach muscle to bone, right? So here's the muscle, here's the bone, so this must be a tendon, patellar tendon. And this is a bone, so this must be the patellar ligament. But a orthopedist might disagree with you and say, no, this is a tendon because it attaches muscle to bone at the bottom, and it's just a tendon with a bone embedded into it. So some people are going to call this whole thing the patellar tendon. So just be aware of that difference. But for our purposes, for our lab exam, we want you to call it the patellar ligament below and the tendon above. Another way to remember that is tendon on top, ligament is lower. So patellar tendon, patellar ligament. And again, if you have irregularly shaped kneecap, you can end up with patellar tendinitis, which just causes inflammation of this tendon and a lot of irritation and discomfort with bending the knee and running and activity. Questions on that? All right, so that concludes the appendicular skeleton. Be sure to look at the flashcards, fill those out, run through them. That's the best way to really understand and commit these different parts to memory.